Good morning, everybody. We'd like to welcome you today to our webinar entitled Renal Issues on HIV. I am Dr. Kate Retana, and I will be moderating today's webinar. We thought of having this special session today because we are currently transitioning towards our clients who living with HIV to be transitioned towards the first-line agent, tenofovir, lamivudine, and dolutegravir. Aside from that, we are also expecting our clientele to grow old with us. And in so doing, we will be experiencing and seeing more patients with comorbidities, not only involving the kidneys, but other organs as well. And we have to prepare ourselves to be ready to manage them on our level, also with our friends from the specialty groups. This is, I think, a very important topic for our healthcare providers so that we will be able to recognize issues that should be brought to our attention, know when to do further workup, and know when to refer. We are happy today to be joined by foremost experts in the field of HIV and nephrology. Next slide, please. We here at SHIP Academy would like to spotlight HIV in our health education. And in our past webinars, we have focused on getting the COVID vaccine for people living with HIV and monkeypox 101 for the community. And currently, our topic du jour is, next slide, please, renal issues in HIV, which will be our main topic. For our program today, we will have a lecture given by our special guest, followed by reactions from our local experts from both the Philippine Society for Nephrology and the Philippine Society for Microbiology and Infectious Disease. Of course, we will open the table for questions from our audiences, which are experts who will be more than willing to answer. So please feel free to put in your questions in our comment section on our Facebook Live. We will be reading this after today's talk, and we will try to do our best to answer all of your questions. I'm joined today by my co-host, Radnir Aranya, who will introduce to you our special guest for the day.
Thanks, Dr. Kate, and good morning to everyone. Thank you for joining us. Now, allow me to introduce our speaker for today. And we're very glad and very fortunate enough that she accepted our invitation. Our speaker for today is a professor of medicine at the University of California, San Francisco, and the renal section chief at San Francisco Medical Center. And he is also connected with the Kidney Health Research Collaborative of UCSF. So let us all welcome Dr. Michelle Estrella. Hi, Dr. Michelle. Good morning.
Good morning. Thank you so much for that kind introduction. I'm just going to share my screen here. Hopefully this works. Okay, I think that worked. The topic today mainly focuses on the workup and management of kidney disease among persons living with HIV. These are my disclosures here, but really this work that I've disclosed here are unrelated to my HIV work. Key points we'll be covering. One is that kidney disease in persons living with HIV comprises HIV-related and traditional causes. Risk of kidney disease depends on genetic predisposition, degree of HIV viral control, and if relevant, hepatitis control, viral hepatitis control, antiretroviral regimen, and comorbid conditions that tend to cause kidney disease, such as diabetes and hypertension. And overall, the approach to kidney disease screening and monitoring has evolved to becoming more proactive and risk-based. And I'll provide some some information related to that in later slides. So I guess setting the stage, why all the fuzz about kidney disease? One, patients with kidney disease have higher risk for a host of adverse events, including heart disease, hospitalizations, and complications from those hospitalizations, including acute kidney injury, and they're much higher risk for death, either related to heart disease or other complications related to kidney disease. And kidney disease is a silent killer, so most patients don't know they have it until it's too late. I think if you look at the literature anywhere, even among patients who are in the late stages of kidney disease, as few as 40% or even less know that they have kidney disease. And knowing a person's kidney disease health or kidney health has strong implications for management of other comorbidities and drug selection, as well as dosing. And this is particularly important in the context of HIV treatment. Now, before I sort of dive into the nitty-gritty of workup of kidney disease and treatment, I thought I'd take a pause and dive a bit on HIV in the Philippines, basically placing kidney disease in that context. So as many of you know, and could tell me probably way better than I can summarize here, the Philippines is undergoing an HIV crisis. The incidence has increased by 174% between 2010 and 2017. And unfortunately, like other places within the world, it's been exacerbated by the COVID-19 pandemic, during which HIV testing dropped, HIV treatment initiation had dropped, and only 63% of patients with known HIV were receiving antiretroviral therapy. And access to certain treatments, such as pre-exposure prophylaxis or PrEP, has been limited, as well as for HIV treatment. And until recently, the antiretroviral therapy has largely been based on lamivudine, tenofovir, disoproxil fumarate, or TDF, and efavirenz. And I mentioned that regimen particularly because it contains TDF, which has been associated with nephrotoxicity or kidney toxicity. This graph was taken from the UN AIDS Treatment Cascade dashboard, and it just shows the incidence of HIV that has increased among Filipinos. On the left-hand side are the trends among females by age in different colors. And on the right side, starkly different from the females, are the incidence of HIV infections among males. And as you can see in this hot pink trend here, the largest rise are among men who are ages 20 to 29, followed by men who are in the ages of 30 to 39. And I mentioned this mainly because they, once they initiated on HIV treatment, you know, they have sort of this additional risk factor, HIV, and potentially its treatment for a foreseeable long period of time. When we look at the vast majority of when we look at the HIV cases by sort of risk factor for acquisition of HIV, you can see that the vast majority of HIV cases are among men who have sex with men, shown here in this row, followed by sex workers, female and male sex workers, and a smaller number are among people who inject drugs. And I mainly place this because our differential diagnosis for kidney disease can involve additional risk factors, including sexually transmitted diseases and certain injected drugs. So what do these trends mean for kidney disease among Filipinos with HIV? When I started looking through sort of the epidemiology of kidney disease in the Philippines, unfortunately, the data are pretty limited, at least the ones that I could reach by the internet, and particularly among persons living with HIV. But if we sort of take a big picture look, the estimates do indicate a pretty high burden of kidney disease in general, not even including sort of putting in HIV in the mix. It's estimated that 1 in 10 Filipinos have an estimated GFR of less than 60 mLs per minute or proteinuria. And if we look at the graph on the left, which shows trends in the incidence of end-stage kidney disease globally from the US Renal Data System in 2007, the Philippines is one of the top 10 countries with the highest percentage increase in incidence of end-stage kidney disease, shown here. There's a high prevalence of chronic kidney disease risk factors, including diabetes, hypertension, and obesity. And so a lot of the thinking or approach towards kidney disease has really shifted towards early detection, because we feel that it is key to mitigating this rising tide of end-stage kidney disease. Similar to the context of HIV, we're hoping to develop a cascade of CKD care. Now, this just shows sort of the trend or the sequence of events in terms of kidney disease, from normal kidney function to end-stage kidney disease and death. And unfortunately, as I mentioned before, because kidney disease is a largely silent disease until the very late stages, most patients aren't diagnosed until the very late stages or even end-stage kidney disease, and they end up crashing on dialysis. In these late stages, unfortunately, much of what we can do to sort of prevent complications of kidney disease have limited effect in these very late stages. And so a lot of focus is on early detection and prevention of kidney disease development to begin with, or slowing of its progression. So with early detection, we can identify patients who are at highest risk for progression and hopefully intensify treatment and implement it in an earlier period of time where they're more effective. So I forgot to mention that throughout this talk, I've inserted a few cases to put things in sort of a clinical context. So this is the first case. It's that of a 43-year-old with longstanding HIV, hypertension, and diabetes referred to your clinic. History is notable for HIV, diagnosed in 2010, with a history of prior AIDS. Fortunately, their HIV viral load is currently undetectable, but they have had longstanding hypertension for 15 years, diabetes for 12 years, slightly elevated blood pressure at present at 148/80, and an A1C of 7%. Their eGFR creatinine is estimated to be about 40 mLs per minute. So the first question, which you can sort of work through your mind, which of the following is correct? A, he doesn't need additional workup at this time. B, his risks of developing end-stage kidney disease outweighs his risk for cardiovascular disease. C, he should undergo CKD screening with estimated glomerular filtration rate, or eGFR, and a urine albumin to creatinine ratio. Or D, he should undergo CKD screening with eGFR and urinalysis. And we'll touch upon why some of these are, why one of this is correct and the others may be incorrect through subsequent slides. So the correct answer for this one is C. He should undergo CKD screening with eGFR and urine albumin to creatinine ratio. So who should undergo CKD screening? Mainly in high-risk groups. And which are the high-risk groups? Those are individuals with a history of diabetes, those with hypertension, those with known cardiovascular disease, particularly heart failure, those who are HIV infected, those who also have viral hepatitis, namely hepatitis B or hepatitis C, those who have had prior episodes of acute kidney injury, those with a history of recurrent kidney stones or nephrolithiasis, recurrent urinary tract infections, very strong family history, or known genetic risk factors. Now, there are different guidelines that you can look at in terms of kidney disease screening and monitoring in the context of HIV. I personally tend to follow the KDGO guidelines, which is KDGO stands for the Kidney Disease Improving Global Outcomes. The KDGO guidelines are sort of our overarching guidelines that we follow in nephrology. So their recommendations are to check serum creatinine so that we can estimate the GFR. And if available, you can check a Statin C to confirm chronic kidney disease and accurately stage the severity of that chronic kidney disease. This at the current existing recommendations are for individuals at very high risk for CKD, those with conditions that make creatinine less accurate, or those in medications with narrow therapeutic windows. For example, we use Statin C to inform vancomycin dosing in the inpatient setting. So that's kidney function. And then in terms of damage, checking a urine albumin to creatinine ratio. That's sort of the overall guidelines. There are patients who may not necessarily have albumin specific or albumin type of proteinuria, in which case you could check a urine protein to creatinine ratio. Those clinical contexts include like amyloid in patients who have sort of recurrent infections, particularly skin infections, those who inject drugs and may have skin popping that leads to recurrent infections or chronic inflammation, secondary amyloid, urine protein to creatinine ratio may be helpful, or those in which drug toxicity may be suspected, in which case oftentimes the proteinuria in that context is more of a tubular proteinuria rather than a glomerular proteinuria such as albumin. And then one can check a urinalysis and microscopy if there's suspicion for glomerulonephritis. These KDGO guidelines, how do they compare to HIV specific guidelines? So these are back, if you look, the data is 2014 with minimal sort of updates on the DHHS guidelines, but both recommend checking a serum creatinine at the time of HIV diagnosis, at the time that antiretroviral therapy is initiated, and particularly if you're initiating a drug that requires either kidney function adjustment for its dosing or potentially nephrotoxic, repeating a serum creatinine within 2 to 8 weeks of that. The main guidelines recommend urinalysis. I personally tend to use the urine albumin to creatinine ratio or protein to creatinine ratio rather than the UA, because it tends to be insensitive for obtaining or measuring or detecting albumin. So why do we worry both about eGFR and albuminuria? There have been several studies that have shown that both low eGFR and high albuminuria are associated with adverse outcomes. And this is a study that was done by the CKD Epi Consortium, which is, I believe, now up to 1 million individuals. They take several cohorts and sort of meta-analyze them. Let me just orient you a little bit to these graphs. So on the bottom or on the left are trends showing all-cause mortality, and on the right are cardiovascular related mortality. On the x-axis is eGFR going from 120 on the right to less than 15 on the left. And then the different color strata here are different levels of albuminuria. As you can see, regardless of which graph you concentrate on, let's take this one. As a person's eGFR decreases, their risk for all-cause mortality increases, but even among individuals, say all with 45 ml per minute eGFR, those with the highest levels of albuminuria have the highest risk for mortality. So once you have the eGFR and albuminuria, you can stage the patient according to their eGFR level as well as their degree of albuminuria. And you can after staging them, you can sort of think through what the next steps would be. So in this case of individuals with stage G3A, G3B, and A2 albuminuria, so an eGFR between 30 to 59 mLs per minute, or an albuminuria of 30 to 300 milligrams per gram, you could monitor. You can also initiate treatment to lower, say, the albuminuria. I placed this slide here mainly as a reminder that the minority of patients with chronic kidney disease, there's only a minority of them who progress to kidney failure or end-stage kidney disease. And in general, most of our patients with kidney disease, unfortunately, die of cardiovascular disease. And so much of the main strategies for just general CKD management also center on cardiovascular disease risk reduction. So one is lifestyle modification, so exercise within their ability, low sodium diet, weight management, and smoking cessation. Second is optimizing their blood pressure, glycemic, and lipid control, aiming for a systolic of less than 120 to 130 millimeters of mercury, especially if they're albuminuric, aiming for an A1C of less than 7%, although we're a little bit more liberal in much older patients, and aiming for an LDL of less than 100 if they are high risk for cardiovascular disease. And then there are targeted pharmacological treatments. If someone is albuminuric or have concurrent heart failure, particularly heart failure with reduced ejection fraction, ACE inhibitors or ARBs are sort of the backbone of treatment. And then there are new drugs that have been developed that show really great effectiveness in terms of slowing the progression of kidney disease, called SGLT2 inhibitors. Among individuals who are diabetic with obesity, high cardiovascular disease risk, or non-proteinuric CKD, and another new class of drugs, if available, are the GLP-1 receptor agonist. And then lastly, among patients with very advanced CKD, we're talking about an eGFR of around, below 45 or 30 mLs per minute. You generally want to think about adjusting medication dosing based on kidney function, avoiding NSAIDs as much as possible, and then managing the acidosis with a goal bicarb level of 22 or greater. Someone had asked for some specifications of, what low salt is. I think by the books, low salt is usually less than 2,000 milligrams per day, but in general, that's really, really hard for patients to reach. And so I generally tend to just recommend practical things like avoiding processed foods, such as ones, meals that you pop into the microwave, canned frozen foods, which tend to be pretty high in salt, and encouraging patients to cook at home as much as possible and avoiding adding salt or using salt substitutes instead. Minimizing their use of alcohol, mainly from a blood pressure lowering standpoint. And then if possible, shifting to a diet that is predominantly plant-based, because one, it tends to be lower in salt and has higher alkaline and potassium content. There may be some modification among patients with very advanced kidney disease in which potassium would be of concern, but there are plants and fruits that we can recommend towards that are healthier but lower in potassium content. And I've just placed this here, which is the DASH diet, and it's a sort of the simple list of things that are preferred and those that we generally recommend in terms of limiting. As you can see, a lot of it is plants, predominantly plants and vegetables, whole grains, low-fat dairy, fish, poultry, beans, nuts, seeds, and then vegetable oils such as olive oil. So we talked about these earlier stages of kidney disease, so A2 and G3A and G3B. What about individuals who had more advanced kidney disease? So those with eGFRs less than 30 mLs per minute, or those with what we would categorize as severely increased albuminuria. In general, the recommendation is to refer these patients, particularly those to nephrology specialty, particularly those that are in the eGFR less than 30 mLs per minute. I'll get to that in, I believe, the following slides. So if you look at the KDGO guidelines, in terms of referral to nephrology, top two, as I mentioned, were an eGFR of less than 30 mLs per minute or severe albuminuria, a rapid progression of their kidney disease, defined as an eGFR decline of more than 25%, or a persistent decline of more than 5 mLs per minute per year. Acute kidney injury. So if a patient was hospitalized with acute kidney injury and they weren't completely back to their baseline or were still in the process of recovering or did not recover. Hints of active urine sediment, such as red cell CAS or hematuria that may indicate a glomerulonephritis, refractory hypertension, persistently high or low serum potassium levels, recurrent or extensive nephrolithiasis, and lastly, hereditary kidney disease, such as polycystic kidney disease. I'm just going to highlight here, these are sort of the guidelines. I personally prefer, having patients referred at a slightly earlier stages, even if it's just a one-time consult, to get them on board in terms of developing a treatment plan that makes sense for that individual. For albuminuria, 300 milligrams per gram would probably capture a lot of patients, and some may argue for a higher albuminuria threshold before referring to nephrology. And I've placed this here, the kidney failure risk equation. This is an equation that was developed and then validated internationally, which basically provides the 2-year and 5-year probability of a patient progressing to kidney failure. It includes urine albumin, sex, age, and estimated glomerular filtration rate. What's nice about this website is you can plug in your patient's information, and it gives you an estimate of the probability of their 2-year and 5-year risk of progressing to end-stage kidney disease. The website now has ways where you can check whether the patient is on an ACE inhibitor or ARB, and you can toggle between the two, and it gives you different estimates with and without treatment. And I found that sometimes it helps in terms of looking at these risks in terms of discussing them with the patient. So continuing with case 1, question 2, which of the following is correct about kidney tests? So 1, or A, serum creatinine-based eGFR equations yield the most accurate GFR estimates. B, the accuracy of GFR equations is greater at higher versus lower levels of kidney function. C, serum creatinine is affected by several factors unrelated to GFR. Or D, urinalysis is sufficiently sensitive to capture clinically relevant proteinuria. The correct answer here is C, serum creatinine is affected by several factors unrelated to GFR. So I just wanted to mention, because it's sort of the main biomarker we use to estimate kidney function, just to provide some understanding of its limitations to hopefully help with interpreting results in individual patients. So we know that serum creatinine, if it's high in the blood, we interpret as the eGFR. So higher creatinine is associated with worse kidney function. But we also know that creatinine is a byproduct of creatine, muscle breakdown, muscle activity. So patients who are very well built, physically active, they can have high creatinines, but that's more indicative of better health. And this is just to say that there are several clinical scenarios in which creatinine may be misleading. So one, context of where creatinine generation is low, it can lead to misleadingly high or healthy eGFR, such as in the elderly, those who are inactive or have undergone major limb amputations, those who may have cachexia in the context of advanced HIV infection or malignancy, those with cirrhosis who often have sort of muscle wasting, or those who are largely on a plant-based diet. And the opposite of that are individuals who generate a lot of creatinine. So those who have do a lot of strength training, have a predominantly meat diet, or taking protein supplements for weightlifting. In those individuals, the creatinine may be high despite a normal kidney function, and they could be mislabeled as having kidney disease. And then important in our context as well are medications that elevate serum creatinine. There are a list of medications, classically Bactrim or trimethoprim, fenofibrate, H2 blockers, and then in the context of HIV, certain antiretroviral medications and pharmacoboosters can actually increase serum creatinine without underlying changes in kidney function. And then the chemotherapy tyrosine kinase inhibitors. I put this here mainly because the upcoming guidelines from the KDGO will focus a larger portion of the discussion or sort of the recommendations around Statin C. It's an alternative or complementary biomarker to creatinine. Unlike serum creatinine, which is sort of a byproduct of muscle breakdown, cystatin C is produced by all nucleated cells at a constant rate. Similar to creatinine, it's freely filtered at the glomerulus and nearly or completely metabolized in the proximal tubule. It doesn't undergo tubular secretion, and so it doesn't have sort of these medication-related effects, and there's no bias by muscle or health status. The existing cystatin C eGFR equations have never really required race adjustments. And I've just placed this here just to show you that there is a CKD epi equation for that as well, just like there is for creatinine. Now, cystatin C is not without its sort of extra-renal influences. So higher cystatin C can occur in the context of obesity, active smoking, high cell turnover conditions such as hyperthyroidism or systemic steroid therapy. And there could be lower cystatin C levels in context of low cell turnover conditions such as hypothyroidism. As you can see, this list is much shorter than the one for creatinine. And so if that's available in certain situations, it may be worthwhile. Now, either biomarker is not perfect, and the E in eGFR stands for estimated. And I placed this graph here just to remind us that there's a large margin of error, particularly among values that are above 60 mLs per minute. So I put this red dot here. If a patient's eGFR is around 60 mLs per minute, their true underlying kidney function or GFR could be as high as 75 or below 45, just showing you that there's a wide margin of error. And that eGFR equations assume constant biomarker levels. So assume constant levels of creatinine, constant levels of cystatin C. And so in the context of acute kidney injury where creatinine is in flux, the GFR estimating equations are inaccurate. Overall, in the sort of the outpatient setting, non-AKI setting, I tend to trend a patient's eGFR over time and look at sort of, is it going down? Is it stable? That sort of thing. So the second case is a 28-year-old woman with HIV who recently initiated antiretroviral therapy with dolutegravir, abacavir, and 3-TC, or lamivudine. Her lab results are as follows. Her creatinine 3 weeks ago was 88 micromoles per liter. Her current creatinine is up to 124 micromoles per liter. Her urinalysis was negative for glucose and protein, and her urine albumin to creatinine ratio was slightly elevated at 45 milligrams per gram. First question is, which of the following is correct? A, the patient has developed acute kidney injury and her antiretroviral therapy should be discontinued as soon as possible. B, dolutegravir is affecting her glomerular handling of creatinine. C, dolutegravir is affecting tubular handling of creatinine. D, she will likely have similar increases in cystatin C. And the correct answer here is dolutegravir is affecting tubular handling of creatinine. So there are several drugs used in HIV management that affect creatinine tubular secretion. This is a pretty picture of a renal tubular cell showing some of the transporters found in these cells. So one is a organic cation transporter 2 and 3, organic anion transporter 2 and 3, and then this multi-drug and toxin extrusion 1 protein. It's a mouthful. So on the left is the blood compartment, on the right is the urine compartment. And we know that creatinine enters the renal tubular cell by these through these organic cation transporters 2 and 3, and then is excreted into the urine by this MATE1 transporter. On either side are drugs that affect or inhibit the transporters. So on the MATE end, or on the urinary end of things, ritonavir, cobicistat, and trimethoprim can impair or impede MATE1 activity. And on the other end, the basolateral membrane, dolutegravir, rilpivirine, or moltegravir can inhibit the organic transporter, cation transporters 2 and 3. All of these effects lead to elevated levels of creatinine in the serum without actually affecting kidney function. And you can see it pretty consistently. This is just an example of dolutegravir, where you can see the increase in serum creatinine occurs by day 14 or 2 weeks after the initiation, and then levels off thereafter. And some of these effects on creatinine and therefore estimation of GFR can be pretty large. This is just some of the median eGFRs from observed in trials. Dolutegravir up to 16.5 mLs per minute change or drop, cobicistat, riltegravir, and rilpivirine. And again, these effects are pretty apparent by day 14 and then level out thereafter. Again, if cystatin C is available, you can consider using a cystatin B-based eGFR, but otherwise, oftentimes what we end up doing is just checking in at 14 days, setting that as sort of their new baseline level for subsequent monitoring. So then now we're up to the causes of kidney disease and HIV contacts and thinking through some of the differential diagnoses. So in general, we have to worry, as I mentioned before, about HIV and non-HIV related CKD risk factors, diabetes, obesity, hypertension, cardiovascular disease, heart failure is a big one, repeated injuries, acute kidney injuries, malignancy, traditional herbal medicines. And then there's the HIV related risk factors, viremia, and antiretroviral therapy, co-infections, particularly hepatitis B or C, syphilis, parasitic infections, all leading to sort of different potential and sometimes concurrent causes of kidney disease. This is now sort of the spectrum of kidney disease that you can anticipate. There's HIV-mediated. Classically, there's HIV-associated nephropathy, although we'll get to this. It's probably pretty low frequency in the Philippines. There's HIV-associated immune complex kidney disease. Some of that is sometimes mixed in with post-infectious glomerulonephritis. And then in patients with very advanced HIV, AIDS, where their CD4 count is in the 50s, there is also cases of thrombotic microangiopathy. And then traditional causes, diabetic nephropathy, hypertensive nephrosclerosis, renal vascular disease, particularly those who have other sort of stigmata of atherosclerotic vascular disease, such as peripheral arterial disease, secondary FSGS, gout nephropathy, mentioned post-infectious GN, other viral-related GNs, such as hepatitis C-related GNs, and amyloidosis. And then drug toxicities, acute interstitial nephritis, Fanconi syndrome, which we'll get to in a bit more detail, crystal nephropathy, Bactrim and Denavir was a classic one, atazanavir is also a possibility, lots of drug-drug interactions, and then illicit drug use, namely cocaine, which can cause ischemic hits to the kidney repeatedly and lead to secondary FSGS. So that's a long list and sort of a broad differential. This is sort of my personal approach to kidney disease workup. When a patient is referred to me, I look at their trends in kidney function decline. If there are sort of certain points where it seemed to drop precipitously or more so than usual, I'll basically take a pencil on the graph and sort of label, what were their medications, what medications did they start, were they hospitalized, all of the events that may have led to that trend. I look whether they're proteinuric and non-proteinuric, their degree of proteinuria, is there hematuria that might suggest something else, and are there other systemic signs or symptoms like swollen, eyelids, peripheral edema that may be concerning for a nephrotic syndrome or liver disease. Patients, with spider angiomas or ascites, those sorts of things you sort of help give clues and inform narrowing of the differential diagnosis. So case 3 is a 45-year-old female with HIV who presents with heavy proteinuria and progressive kidney disease. Her medical history is notable for being a sex worker, having hypertension for 5 years, diabetes for 2 years, no history of illicit drug use. This is her trend here, and I apologize, I forgot to convert it to micromoles per liter, but this is the serum creatinine in milligrams per deciliter, and then here's the proteinuria. As you can see, is sort of slowly, the creatinine sort of crept up, and the proteinuria has increased significantly. Her CD4 count is 100 cells per minute, HIV RNA per millimeters mercury, HIV RNA is high, and her STD screen was notable for a positive RPR. What's the most likely cause of her kidney disease? A, diabetic nephropathy, B, acute interstitial nephritis, C, secondary membranous nephropathy, D, HIV-associated nephropathy, or E, amyloidosis. The answer for this one is secondary membranous nephropathy, probably related to syphilis, and we'll go through this. The differential diagnosis for nephrotic range proteinuria in the context of persons living with HIV. So FSGS is basically sort of like this big basket to catchphrase for a lot of things that develop sort of this pattern histopathologically. But classically, we think about HIV-associated nephropathy, oftentimes partially treated HIVAN, drug-induced FSGS interferon in the context of Hep C treatment, post-adaptive, so someone with morbid obesity or longstanding hypertension, or idiopathic, which presents more the classic nephrotic syndrome. There is also minimal change disease that can present sort of as a primary disease or related to heavy chronic NSAID use or hematologic malignancies. Membranous, such as in our case, could be related to other infections such as hepatitis B, syphilis, solid tumor malignancies. Amyloidosis, primary or chronic inflammation and recurrent infections. Advanced diabetic nephropathy in this patient, she only had it for about 2 years, so unlikely. And then collapsing glomerulopathy. Classically, you would think of a HIVAN. COVID has been associated with collapsing glomerulopathy, other viruses such as parvo V19, and then medications such as pamidronate. And I mentioned this mainly because it's sort of a classic teaching. This is a picture of HIVAN, which shows sort of these collapsed glomeruli, tubular dilatation. They're sort of cystic in nature. And then what we call TRIs, or tubulo-reticulo inclusions on electron microscopy, which are basically accumulations of interferon. HIVAN affects individuals mainly of African ancestry. It is preventable and reversible with HIV suppression. When I looked at sort of the main genetic risk factor for this. One is APOL1 risk variants, and that is extremely rare in Asian individuals. So in green, sort of the Asian areas here, but relatively or moderately increased in North America and West Africa, where it's been described. Here's case 4. It's a 30-year-old male with a rising serum creatinine, clinical course. He's on TDF, lamivudine, dolutegravir since 2020. His baseline creatinine was normal, 88.4, but has had increases of creatinine over the past year, intermittent bouts of hypophosphatemia. And in April of 2022, his creatinine was elevated to 141. Serum potassium was normal at 3.6, serum phos was on the lower end of normal 2.3, and his urinalysis showed no glycosuria but trace proteinuria. Which of the following is correct? A, creatinine rise is likely due to dolutegravir's effect on renal tubular secretion of creatinine. Plasma levels of TDF correlate with its nephrotoxicity. C, his kidney function decline is too slow to be attributed to TDF nephrotoxicity, or D, he's unlikely to have TDF nephrotoxicity as no glycosuria. The correct answer here is B, plasma levels of TDF correlate with its nephrotoxicity. So this case represents TDF-related nephrotoxicity. The first one here, A, is incorrect mainly because we're pretty far out from that 2-week period where dolutegravir's effect would have stabilized by the time the other elevated creatinine had popped up. So TDF induces proximal tubulopathy. What happens is that TDF is sort of in the plasma, is taken up. The active form is taken up by the organic anion transporter 1 in the proximal tubule. In the context of either dehydration or slowing where tenofovir accumulates within the proximal tubule cell, it basically causes mitochondrial toxicity and leads to proximal tubulopathy. The main risk factors for TDF-related kidney toxicity are chronic kidney disease. A TDF is contraindicated in patients with an eGFR of less than 70 mLs per minute, lower body mass index, use with other kidney toxic drugs, use with ritonavir-boosted protease inhibitors, and then any context that can lead to sort of decreased GFR, such as dehydration or low blood pressure. The classic presentation is partial or full Fanconi syndrome. Patients will present with proteinuria, generally a mix of albuminuria and tubular proteinuria, glucose in urine despite normal blood sugar levels, sometimes low blood potassium and phosphorus levels, and sometimes acidosis. There have been case reports of diabetes insipidus, and it has been associated with acute tubular necrosis or acute kidney injury. The diagnosis is based largely on sort of, the trend and laboratory data. On urinalysis, we look for glucosuria or glucose wasting, and then you can calculate the fractional excretion of phos or FePhos. Each year of TDF use on average has been associated with anywhere from 16 to 33% increased risk for chronic kidney disease and about a third increased risk of proteinuria. And I've placed this here, which shows sort of the clinical features of 10 patients who presented with phosphaturia, because I think sort of gives a clue of the variety in terms of clinical presentation. So you can see some patients were obviously in the serum hypophosphatemic, but there are others who weren't nearly as obvious, sort of on the lower end of normal. Some, the more severe ones, but even those with not so severe serum hypophosphatemia had glucosuria. A lot of them were on the drugs for multiple years, and so it can present pretty late in the treatment with TDF. And then I place this here because there's this concept of creatinine creep. A patient may have it may not, an increase from 0.8 to 1.3 may not necessarily catch someone's eye, but if you translate it into an eGFR change, some of these are pretty substantial. The earlier you catch TDF toxicity, generally the better, and the more reversible it is. This is a small study, 24 individuals who initiated TDF and had to be discontinued because of kidney disease. At the time, prior to starting TDF, their GFR was around 74 mLs per minute. At the time it stopped, on average, it was down to 51. About 42% only 42% of individuals who stopped TDF were able to return to their baseline level of eGFR in the 70s. So partially reversible, earlier discontinuation, the better, once nephrotoxicity is detected. So case 4 continued. At his last follow-up visit, the patient's HIV RNA was undetectable. Since he developed TDF-induced nephrotoxicity, his provider decides to switch him from a non-TDF containing regimen. Question 2, which of the following is correct? A TAF-based regimen is contraindicated in this patient with an eGFR of 48 mLs per minute. B, switching to a TAF-based regimen would be a reasonable step. C, discontinuation of TDF would lead to full reversal of our kidney function. D, TAF would lead to a more favorable lipid profile. And the answer here is B, switching to a TAF or non-TDF based regimen would be a reasonable next step. And I've just listed here some optimal TDF-free regimens for persons living with HIV and concurrent CKD. I won't detail these too much, other than some of this information is available online and is regularly updated. So why is TAF less nephrotoxic? TAF in general isn't fewer or a less amount of it is in active form, and fewer actually gets into, or much less of it gets into the proximal tubule, and so less propensity to accumulate within the proximal tubule cells and cause mitochondrial damage. When they looked at individuals who switched from TDF to TAF, this was just one of the studies showing basically that those who were on TDF pre-switch to TAF had stabilized kidney function after switching to TAF, and they just included another group who was not on TDF and also just showed sort of a stable level of kidney function. And this is a relatively high-risk group. 42% had proteinuria, 39% were hypertensive, and 14% were diabetic. They also showed that there was an improvement in proteinuria, albuminuria, and tubular proteinuria among patients who switched from TDF to TAF. So in orange are individuals who were on TDF, and you can see they had a decline in their urine protein to creatinine ratio, to urine albumin to creatinine ratio. And when they looked at tubular biomarkers, retinol binding protein and beta-2 microglobulin, there was also an improvement in those levels after switching from TDF to TAF. What about individuals who were never on TAF and initiating antiretroviral therapy with TDF versus TAF? This is just showing eGFR and proteinuria. In purple are individuals who initiated antiretroviral therapy on TAF versus TDF in orange. So you can see their eGFR was higher at the end of the study in those who initiated TAF versus TDF. Their levels of proteinuria were also less compared to the TDF group, and same in terms of biomarkers of proximal tubulopathy, such as retinol binding protein and beta-2 microglobulin. Overall, TAF had a better sort of renal safety profile than TDF. Moving on to case 5, this is a 56-year-old male with CKD and dyslipidemia. Past medical history notable for hypertension, CKD with an eGFR of 45 mLs per minute. HIV that was treated with ritonavir boosted darunavir and FTC. Labs at baseline had a creatinine of 133, an LDL of 140. The patient was initiated on atorvastatin, and 2 weeks later, he began having profound weakness and generalized pain. He presented with a very elevated creatinine of 707 micromoles per liter. His UA showed 3+ proteinuria, 3+ hemoglobin, but no red blood cells. Question, which of the following is most correct? A, the patient likely developed a darunavir-induced acute interstitial nephritis. B, the patient likely developed drug-induced rhabdomyolysis. C, the creatinine rise likely represents ritonavir-related perturbations of renal tubular creatinine secretion. Or D, the provider should consider switching the patient to raltegravir with ritonavir-boosted darunavir. The correct answer here is B. The patient likely developed drug-induced rhabdomyolysis. Rhabdomyolysis in this context is mainly due to drug-drug interactions, and statins are pretty problematic when they're co-prescribed with concurrent fibrates, HIV, protease inhibitors, cobicistat, Hep C protease inhibitors. Just listed here the most problematic ones: lovastatin, simvastatin, rosuvastatin, and then others that generally require significant dose reduction. Raltegravir has also been associated with rhabdomyolysis, but overall, particularly the protease inhibitors have a lot of drug-drug interactions, and so when in doubt, I recommend just checking for interactions. And I've placed here a great guideline in terms of looking up some of these drug-drug interactions. The etiologies of ambulatory AKI. This is back from 2000 to 2002, but honestly, I don't think much has changed in terms of the underlying causes of acute kidney injury. A large portion are still related to pre-renal, dehydration, infection, cirrhosis, intrarenal, as I mentioned, drugs, interstitial nephritis, and then crystalluria. I think less so now, but still can be caused by non-HIV treatment-related drugs. And I'll just briefly mention acute and chronic interstitial nephritis here because we see it not uncommonly. It can honestly occur with any drug, but here are the usual suspects to think of: NSAIDs, antibiotics, antivirals, such as acyclovir, diuretics, those that contain sulfa components. Proton pump inhibitors have been associated with acute or chronic interstitial nephritis, allopurinol, and then crystalluria, as I mentioned. Can present as acute kidney injury, and in some patients, it could be sort of this slow smoldering creatinine creep. In some patients, it can be severe enough where they present with rash, fever, malaise, but a large majority of them may not necessarily have symptoms, and they happen to be found to have, elevated creatinine levels on monitoring. So just to end, take-home points: kidney disease in persons living with HIV can result from a confluence of HIV and non-HIV related factors. Early detection of kidney disease is crucial to really avoiding further injury and to initiating appropriate treatment. For patients with very advanced kidney disease, so an eGFR of less than 30 mLs per minute, strongly consider co-management with a colleague in nephrology, particularly one familiar with HIV and its treatment. Oftentimes, a lot of what we do in the very advanced stages of kidney disease is mitigating the cardiovascular disease risk and also preparing them for dialysis or sort of advanced sort of management or care, whether they want dialysis or not, and whether palliative care may be a more appropriate route. TDF-related nephrotoxicity can be insidious. It's not necessarily obvious on serum labs. Again, sort of trending your own sort of patient's labs, particularly creatinine, is often insightful. And then drug-drug interactions are numerous, particularly with pharmacoboosters and protease inhibitors. And when in doubt, double check. And with that, I'll stop sharing and happy to discuss further.
Thank you so much, Dr. Michelle. That was quite a comprehensive talk that we just heard, and I must admit I took down notes so that I'll be ready to ask my own set of questions later during the Q&A. So we now want to hear from our beloved local reactors. I'll turn this over to Rad to introduce them.
Thanks, Doc Michelle, and thanks, Doc Kate. Okay, let me introduce our local reactors. Firstly, he is a nephrologist and internist and the head of nephrology section of Our Lady of Fatima Medical Center, or Our Lady of Fatima University, and a consultant at San Lazaro Hospital. Also, he is a visiting consultant at National Kidney Transplant Institute. No less than Dr. Albert Lu. Aside from Dr. Albert Lu, we also have another reactor, an IV specialist and internist at the same time. She is a faculty at UPPGH, Dr. Christine Penalosa-Ramos. So let's welcome Dr. Albert Lu and Dr. Christine Penalosa. Sirs and ma'am.
Okay, we'll kindly call on Dr. Albert to share his insights on Dr. Michelle's talk. Thank you.
Yeah, thank you, Radney, for that kind introduction. And also, Michelle, that was a very nice, insightful discussion. No? I said I even took down notes. So I think I like the point that you mentioned about the referral that we have to share with the nephrologist, that we don't wait like a 300 milligram. That I think the guideline says it's 1 gram per gram, right? Yes, 1 gram per gram. But 300 milligram, I think it's a nice start to create a blueprint for our patient. I think I agree on that. Yeah, that's we have to treat earlier the patients now. And then you mentioned about the projected risk equation. I think this is nice also to show to the patient what is expected in the following years. No, somehow we don't want to create a fear, but we want to show the patients how we want a good medical option treatment that he would follow on us. No, and then you also talk about the rising creatinine. Both sides you have those transporter. No, so a sudden price. Always check probably the drug mechanism on the flow of the creatinine secretion in the tubules. And I also like the way you approach. You mentioned about the eGFR versus time, the tempo. Your approach in looking at the patients. I think that's good. You want also to follow up what really happened when you try to adjust something and what happened to the eGFR of the patient. Also check on the proteinuria and the causes possible, and also on the urine analysis, like patients presenting with hematuria. And then the last one, the physical examination. I think it's really basic and outstanding for us to look at based on the discussion. And then subsequently, you brought us to the different cases. The tough in our setting, the hospital, we still don't have the alafenamide, the tenofovir, but we try to switch it if in case to abacanib. So we don't have this one. Probably the acquisition or the budget for that is not obvious yet. So that was also a nice discussion on the difference between using tenofovir, lansoprazole, and the ALAF side of patients, no? And eventually, I would say, the chronic kidney disease is basically a comorbidity that with a clinical significance, especially in patients with HIV. So, and it's closely related, as you mentioned, with mortality, morbidity. As the cohorts of this group of patient ages, comorbidity increases and CKD becomes prevalent. The model of care probably would try to evolve and attune to the special needs of this group of special patient, the healthcare needs of this group of HIV patients. And despite this widespread antiretroviral therapy, the prevalence of CKD is still rising. So, and it's increasing is probably due to this non-infectious comorbidity that the patient have, and also some of the antiretroviral toxicity and other drug interaction, which we have to analyze. And once CKD sets in, it's often relentlessly, it progresses to eventually to end-stage renal disease. So we should earlier, as you mentioned earlier, identify patients who has these risk factors for CKD and try to do screening earlier and intervene so that we can get an improved patient's outcome. Okay. Now, in September 2015, the several countries have adopted the so-called Sustainable Developmental Goals, which try to set 15 years. So from September of 2015, so 2030, that we have to lower or probably stop the AIDS epidemic. So that 2013 is the target year. So aligned to this program, the expansion of access for treatment in HIV has been there, and it's it has been a nice program for everyone to enjoy those treatment to our patients. So I think overall, if I may add to what Michelle mentioned, that I think three important factors should be in the program of HIV management. This serves as like a operational action plans, a process that we could follow. First, we have to provide awareness to our patients. Try to discuss probably the medical issues, the current status of the patient, so that the patient would know the reason why he has to be treated. So awareness is number one, and probably provide accessibility to some information. These are truthful, factual, updated information for our patient. And finally, I would say we have to provide the availability of those drugs. In our settings, like in some of the government hospital, we don't have those like TAF. So we probably would use another drug. So as you try to prescribe and give the prescription to the patient should be able to get those medicines. So I would say the availability should be there. Now, if we try to sustain these three programs, I think we can achieve the 2030 goal that was set up by this so-called sustained global developmental goals. So that would hopefully stop or probably end the AIDS epidemic in our region. So I think this should be supported, that this kind of operational plan should be continuously supported so that we will be able to achieve the dream of the stopping the AIDS epidemic in the country. I think that's all. Thank you.
Thank you so much, Dr. Albert Lu. May we now call on Dr. Christine Penalosa to give her reaction.
Hi, good morning, everyone, and good morning, Dr. Michelle and Sir Albert. Indeed, the 1 hour lecture of Dr. Michelle is super comprehensive in terms of dealing with the renal
issues pertaining to HIV. I also took down some notes. Thank you. And we will also share it not only with our colleagues, but our trainees as well of the IB program. Okay, so importantly, the emphasis on urinalysis as part of the initial workup and also the serum creatinine. Excuse me. Really has some value as we have a local study as well published back in 2014 where a small cohort of 198 patients in a tertiary hospital where they did urine dipstick and they found out 9.6% albuminuria among these patients with microalbuminuria of about 63%. And the significant
factor there that they saw was that the longer that the patient was not initiated on antiretrovirals, the more they had proteinuria or albuminuria in their urine as compared to those who been started on antiretrovirals, even at mostly at a year of when they're already virally suppressed, because that's the time that we are able to do our viral loads through the free program. Regardless of stage in their HIV disease, the albuminuria has significantly improved or disappeared with antiretroviral treatment. And then with regards to serum creatinine, as you know, that our drug combination available here in the Philippines, because it's given for free by the government, by the Department of Health, is mostly tenofovir based. And in another local study published also in an international journal back in 2022 by Dr. Puenzalido and Dr. Abad, who are both our ID colleagues as well. They had this 654 patients on tenofovir. This is the isoproxil tenofovir, the TDF. The results there was with a relatively young cohort of mean age of 29 years old, a predominantly male population. There was a 50% nephrotoxicity noted in this study, and at 20 months of treatment with the TDF regimen. And the significant factor that they found out was low CD4, predicting a subsequent 20% EGFR decline. So that's pretty high. And I think the emphasis on the serum, the EGFR of less than 30 being referred to nephroservice is a good recommendation and a good start for us ID specialists to really remember and to do the early referral to our service, to your service. And then in this particular study, there were only 2% with hypertension and 1% diabetes among this cohort. So because this is a relatively young cohort, so we have less comorbidities, but since they're now aging and more, a lot of these patients are now more than 10 years on antiretrovirals, we really need to have other options to be able to avoid the TDF nephrotoxicity. So again, in line with the same with Sir Albert's comment on going towards the goal for the SDG and the rollout of the LTD or the dolutegravir-based regimen, we're really pushing this together with the government and all the other treatment hubs, because to just emphasize the advantage of the LTD combination is that indeed there's a rapid viral suppression. So the more that, or the faster we get them suppressed, then the less we will see complications related to their underlying disease and complications as well with the drug combinations that they're taking. And then The LTD also has low toxicity, fewer drug interactions than what we're using now, and then the high genetic barrier, okay, and to develop drug resistance. So I know that even in our center, which is the Philippine General Hospital, which is a big government hospital, we haven't had transferred our patients to the LTD because of some supply problems from the government, but with assurance from the Department of Health that there will be more supplies coming in. So we are more confident that we will sustain the LTD for our patients, especially the treatment naive individuals and those that we have recognized already as having complications from their previous medications. And as Dr. Albert mentioned about tenofovir alafenamide, I'm happy to say that it is available locally. We can actually buy it in Mercury Drug, or some of the pharmacies of the hospitals have tenofovir alafenamide. But on the part of our HIV patients, this will mean additional cost because this is not free. They will have to shoulder it out of their own pockets if they have to be shifted to the tenofovir alafenamide. But at least there is now an option to that. Though abacavir has been available for the longest time, the supply is not as sustainable as well. There are months wherein we don't have abacavir, and we also share abacavir with the pediatric HIV patients since it's one of their backbone medications. And from recent studies or trials to mention, such as the Tango and the Salsa trial, some of our counterpart countries, such as the US, have already started recommending a dual antiretroviral tenofovir sparing regimens. So they have combinations of dolutegravir and lamivudine. We see this as a near future options for us. What is more important locally now is for our continuous supply of the LTD, addition of the TAF probably to the regimen of the treatment hubs, and also the continuous supply of solo dolutegravir, so that we don't also have to keep using or shifting back our patients with tuberculosis to the efavirenz-based regimen, because that's what we do. We are still limited by the capacities of our health system here, and we don't have much options. For our patients who have more resources, we do try to get other treatment options from our partner pharmaceutical companies, or we refer them to higher centers, or like the Thailand Red Cross. We do have those linkages with them to be able to access better or newer antiretrovirals. As a recommendation from an ID specialist, I think we have to, with this epidemic of the HIV in the Philippines, we are not already satisfied with just treating those patients, but we're also moving our efforts towards prevention. Hence, the rollout of the pre-exposure prophylaxis is really something that we also have to do in the treatment hubs and for all HIV practitioners, and so that we will prevent patients from getting actual HIV infections and sustain them on the pre-exposure prophylaxis. This is, by the way, free. It will be rolled out, free eventually, when because there's already the administrative guidance to the pre-exposure prophylaxis. So that's one. And then lastly, I think Sir Lou, the CPG for HIV, I think will be updated soon. I think nephrology should be also part of that update on the, especially on the CPG on OIs and also complications on HIV treatment, so that our network will be strengthened, and there will be like not automatic referrals, but early referral system with the nephrology service for our HIV patients, especially those in the treatment hubs that are standalones or LGU connected, because they're not all hospital based, and it would be good for network or a process to be established for referral of our early kidney complicated patients. Thank you.
Thank you, Doc Ketty. I'll give Dr. Michelle a few moments to reply to both reactions before we proceed to our Q&A.
Thank you, Kate. I appreciate the really thoughtful, comprehensive comments from Drs. Liu and Penalosa. I think, gosh, where to start? I think, you know, in terms of the movement towards less TDF use, I think is important. I think from a kidney health standpoint, the percentages that you mentioned in terms of the cohort of 690 or so individuals who were found to and 50% of them having had kidney disease, I think it's a large number, and just sort of extrapolating that to the rest of the population in the Philippines with HIV, you can imagine there's, you know, potentially expanding number of patients who have underlying kidney disease that just hasn't been detected. So I think the focus on early stage sort of detection of kidney disease is going to be key. The movement towards PrEP is great. I totally agree with that approach. The one thing that we've learned, you know, based on sort of the trials in PrEP, you know, the initial ones, there are now TAF-based PrEP for certain sort of clinical situations, but largely patients are being treated on PrEP based on TDF. But the safety profile in patients who are HIV negative taking PrEP is actually pretty reasonable. Most of the risk for TDF-related nephrotoxicity are found in older patients. We're talking like in their 50s to 60s years of age based on post hoc analysis of trial data. So I think that's really I think promising in terms of addressing both the concern for, you know, stemming the tide of HIV infection as well as kidney disease. Kind of think there were other thoughts that were circulating in my head as you were speaking, but yeah, I think in terms of co-management of kidney disease and HIV, you know, I've been fortunate to at each of the hospitals I've worked at to have sort of this close-knit communication with the HIV providers. In my old institution, we had both, you know, we had nephrologists in the HIV clinic who were very focused on just HIV, and they were the two sort of go-to people for anything related kidney-wise in our patients with HIV and sort of this co-management. So it really streamlined a lot of sort of the thinking, and they knew the patients very well. And, you know, it took the pressure off of the HIV practitioners or HIV providers, and that they can concentrate on the HIV related issues. And then there's the nephrologist sort of as the support team from a kidney standpoint. And they were great resources for, you know, adjusting dose of medications, thinking through, you know, what other medications can we give? When would a kidney biopsy be reasonable to do? Is it even needed? those sorts of questions. It was really helpful to have colleagues in that regard. I recall in the beginning of the HIV sort of epidemic year, my training was in the early 2000s when not everyone was yet on antiretroviral therapy. So it was nice to have even sort of nationally a network of people to run cases by, patients presenting with, sort of out of the box type of diseases and getting advice or sort of like this group expert opinion on what would be sort of the best clinical approach for individual patients as well. The other thing just sort of related to TDF that I didn't touch upon in my talk, mainly because of time constraints, is besides kidney disease with TDF is sort of the bone related side effects. And I failed to mention it, but just something to think about. And I wonder in your practices sort of how that's dealt with, or is it monitored, or not an issue at all?
We do recommend already doing the DEXA scan to some of our patients, but it's always the financial constraint that's it's holding them back. But when we do, but we don't have much data on it because we haven't been able to do those DEXA scan. But we do recognize that we already need to, especially our 40 and above cohort, I think we should really start doing those scans.
Thank you, guys. That was such an engaging reaction and counter reaction. We'd like to proceed now to our Q&A. As you notice, we've put some questions up already on our board, and we're going to ask Rad and Alan to facilitate this discussion. All right, thank you.
Thanks, Doc Kate. So thank you to our reactors. Let me just put a spotlight on Alan and Doc Michelle before we proceed with the Q&A.
Okay, thank you very much. Okay.
Go ahead, Alan.
Okay, thank you very much again, Dr. Estrella and our two reactors for a very informative discussion. And again, we are opening the floor to our participants, to our viewers in FB to ask questions. And the first question is from Mr. Lunar Rolly. So the question is, here in the Philippines, most hospitals only have creatinine to estimate GRS. However, we see a lot of patients on ARVs with electrolyte imbalance despite within normal creatinine. Is it possible that the culprit is HIV-AN or ARV-associated tubular damage?
Got it. So with HIV-associated nephropathy or HIVAN, it would be unusual for the creatinine to stay normal or to be stable. That's sort of the classic, rapid progression within weeks is sort of the classic HIVAN pattern in terms of kidney function. Not necessarily, it's not necessarily associated with any electrolyte disorders aside from those caused by rapidly progressive kidney disease. So like high potassium levels, acidosis, that sort of stuff towards the sort of the later stages of that progression. Electrolyte imbalances, I personally tend to think about medication-related side effects. So diuretics are probably the most common things. So I think I tend to review the sort of, I always think nephrologists are sort of like very specialized pharmacists. are pharmacologists in that we spend a lot spend a lot of time looking at medication lists. So I tend to look at medications and see what, depending on the electrolyte being sort of perturbed or, slightly off. I think through different medications, proton pump inhibitors have been associated with low magnesium levels, diuretics, low potassium levels. When it comes to antiretroviral therapy, the classic one that causes electrolyte abnormalities is TDF, and it could be pretty subtle. If you can recall the 10 patients who were presenting with high levels of fractional excretion of phosphorus, I mean, they're very subtle. They're like low, towards the low normal of serum phosphorus, slightly, maybe slight acidosis, nothing that would necessarily catch your eye, on a quick glimpse. But if you knew your patient and you saw their trends, that would give you a clue that something might be up that's related to TDF.
Thank you very much. And another question from our viewer is from JD Mick, Doc Mick. What can you advise a primary care provider handling a case of elderly PLHIV with CVD, already on TAF, TDG, and renal adjusted 3TT with progressive decline in creatinine clearance, who will have a delay in assessing in nephrology? What can be utilized by these patients in the meantime? They cannot access nephro consult.
So, if I heard correctly, it's a patient with HIV already on antiretroviral therapy who is elderly, has cardiovascular disease and progressive kidney function decline. I think that was sort of the overall patient history. Typically, it's looking at the risk. So if their HIV is already controlled, your main worry is the CKD portion of their overall condition and mitigating its progression. Things I think about are one, if it hasn't been done, checking the albuminuria, because that sort of determines what medications I should be offering the patient that could slow their kidney disease progression. If they're albuminuric and their blood pressure can handle it, I would tend to recommend starting something like an ACE inhibitor, like lisinopril is sort of, a main one that we do. So that sort of class of drugs will, if they have proteinuria or albuminuria, should lower it. I'll often recommend a low sodium diet because it sort of goes in and sort of augments the effect of the ACE inhibitor or angiotensin receptor blocker. And then the other thing is talking with them about their cardiovascular risk. That kidney disease in and of itself is going to put them at a much higher risk for cardiovascular disease or subsequent events if they've had events already. And so working with them to getting their risk factors for cardiovascular disease under control, because getting those under control would also generally benefit the kidney function. So cholesterol, controlling their blood pressure. If they have diabetes, controlling the diabetes. If they're obese, lowering their weight to a reasonable point. So the usual chronic disease management in that context. But the main thing is making sure the urine albumin is checked, because that would help in terms of deciding to start an ACE inhibitor or not.
Okay, thank you so much, Doc. Another question from Barry Vickery, another viewer from our FB Live. Up to what level of serum creatinine can be safely give or prescribe LTD?
LTD. Remind me what LTD is. Is that?
It's the dolutegravir, tenofovir, and lamivudine.
And the tenofovir is TDF or TAF?
It's TDF.
So I don't know the creatinine cutoff, but an eGFR of less than 70 is usually the threshold in which, if you look at sort of the drug labels, TDF is contraindicated.
Okay, thank you so
Alright,
much.
thank you.
Okay. We have a question from Dr. Kate. Dr. Kate. Okay. Many patients will be shifted to TDG from EFV while still on TDF backbone, and these may result in increase in creatinine. At what point do you think that this warrants attention? What happened during the 2-week TDG stabilization period?
Okay. Let me get, so a patient, say, switches to a medication who is on TDF, gets switched to a medication that also affects creatinine. Generally, if resources allow, I generally check upon switching, sort of generally check what their new creatinine is at 2 weeks. And then I use that at baseline and then repeat it, at their next follow-up, just to make sure it's stable. If the creatinine continues to increase beyond that day 14, when we expect the drug-related effect on creatinine to have stabilized out, then I start thinking, am I missing something that's causing kidney injury? And then go back, review the medications, all of that sort of same approach.
Can I have a follow-up question, Dr.
Sure, Doc.
Michelle? So when we say that there's, upon shifting to a new drug, so let's assume that someone who was on TDF and efavirenz is shifted to TDF plus dolutegravir because that's the general trend nationwide. Some will expect, because of the inhibition of the OCT,
Yep.
some will expect an increase in the creatinine levels in the blood without necessarily affecting kidney function. And then in the 2-week period wherein we're going to observe what's happening, we're expecting an increase in creatinine, which will be of the same value, more or less, but will not further increase. Is that what we are going to expect?
Yes. So the generally, if you check it, I tend not to check it immediately after initiating the change, the dolutegravir. I wait the 2 weeks, check it then. I would consider that sort of their new baseline, accounting for the dolutegravir effect on the creatinine. And then, in subsequent rechecks of their creatinine, if it's stable, that's reassuring that there is, that there is no sort of injury ongoing that we can perceive. If it's still increasing above that new baseline from day 14, then I do sort of just think through and make sure that I'm not missing anything that could be causing a kidney injury.
Great, perfect. That's a very helpful tip, Dr. Michelle, because it'll save our local nephrologists a lot of unnecessary referrals, especially those who are tracking their creatinine and then they suddenly shift to TLD and whoop. So now
I've lived through that.
Yeah. Let's reset our baselines and try to use eGFR instead of just the serum creatinine as the basis. So that's my takeaway. So thank you. And Alan will ask my other questions.
Okay, thank you very much, Dr. Kate. Another question, at what point do we advise our patients who take protein supplements such as whey protein and branch chain amino acid to discontinue them?
The concern for protein is usually, sort of excessive intake of protein is usually among patients who have very advanced kidney disease. One, there's literature, I would say probably from the 1990s, where it showed that high protein intake could lead to sort of faster progression of chronic kidney disease, with the thought that it sort of overworks the glomeruli. The other is in patients with very advanced kidney disease. So we're talking, patients with an eGFR of, below 20, 15, 20, that they are actually below 15, that they may present with symptoms of uremia earlier than a patient who is sort of on a plant-based diet because of the potential higher sort of burden of toxins that can accumulate. So that's one context. There also have been other studies that have shown in patients with nephrotic syndrome that a high protein diet could contribute to sort of this hyperfiltration. I guess sort of conceptually sort of a more overworking of the kidney to compensate for that protein intake, and could lead to faster progression of kidney disease. But in general, I don't mess with it outside of those two.
Okay, thank you very much. Another question, Doc. This lipidemia and NAFLD is starting to be seen more among PL-HIV. Seeing that some statins have interaction, especially with ritonavir, would you recommend shifting those currently in liponavir, lopinavir, ritonavir, be shifted to TLD?
TLD.
Yeah.
I'm not, TLD again is?
But TDF and dolutegravir.
Oh, thank you. Okay. We use different sort of terminology here.
sorry.
Okay. Oh no, no worries. I'll remember at some point. Okay, so the question in this is patients who have dyslipidemia, who are on statins, and whether they should be switched off of those,
Of a boosted ritonavir regimen to a dolutegravir one instead.
I see. It depends on the drug. I think that, usually the effect, the drug-drug interaction is pretty immediate. If a patient was going to have a drug-drug interaction, they're usually pretty profound and not missable. So if a patient is already on atorvastatin, sort of on a low dose of atorvastatin and well controlled on their current regimen, I wouldn't necessarily feel strongly about switching them to a non-ritonavir boosted regimen, and just monitoring them for any symptoms that would be concerning for muscle damage. Yeah, so it sort of depends on the individual. If they're already on a reduced dose of atorvastatin and they're asymptomatic, I wouldn't necessarily switch them for that reason alone.
Okay, great. So the rhabdomyolysis will come early. It won't.
It'll be pretty dramatic in terms of presentation.
All right, thank you.
Okay, thank you so much. Another question from our viewer, from Dr. Karen of Lacasandide. How to manage persistent glucosuria in HIV patients with normal blood sugar level?
In that case, so if you have a patient who has normal blood sugar levels but is losing or wasting glucose, you want to think about what could be causing that. In the context of HIV, TDF is the first thing that comes to mind. And so you would want to consider switching that patient to something else that is not TDF based, because that's sort of a pretty clear indicator that they're probably having some early signs of proximal tubulopathy, and if left unchecked could progress to more overt acute kidney injury or acute tubular necrosis. If they're not on TDF and they're having what we call normoglycemic glycosuria, so wasting of glucose in the urine in the context of normal glucose, and they're not on TDF, you'd want to think of other issues that can lead to Fanconi syndrome. And oftentimes those are sort of hematologic malignancies, like, like light chain nephropathy, that sort of stuff. Yep,
Okay.
that's it for that one.
Okay, thank you very much. Again, we are encouraging our viewers to ask questions to our resource person. Uh, hmm, there is a I received a private message from Benji, our viewer from the FB Live. Um, Actually, he's sharing some questions. My creatinine ri- rise to 1.6, and he is on the 21st days of TLD now. Is it because of the TLD?
It's hard. It's hard to say without knowing the prior creatinine, but it would be something that I would recommend talking with his HIV provider or his primary care doctor to think through whether it needs further investigation or treatment.
Thank you, thank you. There is a question. Are there cost-effective community-based screening program for CKD? If so, how can we capacitate our community HIV service providers and case managers so they can assist our patients with it?
Cost effective. In the US, there are sort of these free kidney disease screening programs, or screening for risk factors for kidney disease, that's conducted by different nonprofit organizations, like the National Kidney Foundation here has them throughout the country. They're generally manned by volunteers, or even budding medical doctors who eventually budding wannabe medical doctors are often sort of leading those efforts as well. There is one study that comes to mind. I'm blanking on the name. Sorry. Well, it comes to me. There was a study that was conducted in, I believe, East Africa, where they actually paired HIV screening with screening for hypertension and diabetes, sort of this general umbrella of care and screening. And that could provide sort of, a framework by which to do this in low resource settings. The study is called, it just came to me, it's called SEARCH. And I can provide the link to Kate. It was a clustered randomized trial, community-based, where they tested that approach out.
Again,
But I think in terms of if you're going to screen for CKD, just having sort of the backup providers to support individuals who are found to have kidney disease or have evidence of say albuminuria, having that backup in terms of informing them of next steps or that and treatment.
Okay, thank you very much, Doc Estrella, for guiding us and sharing your expertise on this matter. And we would like to thank you and our two reactors for being with us. And also, we would like to thank our viewers from the FB Live for asking questions, and this will help us to be more efficient and effective in doing our services to our PLHIV brothers and sisters. Back to you, Doc Kate.
Thank you, Alan. So that ends our question and answer portion. And now we've come to the end of our program. And I would like to thank everybody for actively participating in our webinar today. I'd like to thank Dr. Michelle, who has taken time off of her extremely busy day to spend time with us, even though she's halfway across the world. We really, really, really appreciate this, and please do appreciate that it is something that we definitely need. This type of learning is something that we should share among all our HIV healthcare providers to guide us better towards our patients' better outcomes. So again, thank you so much. I'd like to call on our actors as well. Thank you to Dr. Ketty Penalosa and to Dr. Albert Lu for spending your morning with us and Dr. Michelle Knight. And we'd like to thank everybody for joining and hope that this will help us in our continued efforts to contribute to the betterment of PLHIV in our country. Dr. Michelle, any last words from you po?
I just want to say thank you so much for having me, and I'm so glad to have met everyone on this platform, and I appreciate everyone's engagement. The questions were amazing and very thoughtful, and if I could be of having help in any way, you guys know where to find me, and I'm around.
Thank you. Thank you
Happy
din po,
to be a
Dr.
resource.
Albert and Dr. Ketty. So we'd like to bid everyone goodbye and happy lunch.